Now let us discuss about anemia. Anemia, we know anemia is a medical condition that is characterized by deficiency in the number and quality of the red blood cells or the hemoglobin in the blood. The hemoglobin, we know HB, is a protein in the red blood cells that carries oxygen from lungs to the rest of the body. Now anemia can result from various underlying causes, and it reduces the ability of blood to carry oxygen to tissues throughout the body. Now we can classify the anemia into pathophysiological mechanism or morphological characters. The first is the pathophysiological classification of anemia. So the first is anemia due to the blood loss. So that can occur suddenly due to the significant blood loss from the traumatic injury, or the blood loss, it can occur through the acute post hemorrhagic anemia. That can occur due to the blood loss such as from the traumatic injury or surgery, or anemia of chronic blood loss that develops over time, like GIT bleeding or heavy menstruation periods, menstruational periods. Other could be anemia due to impaired red cell function, like there could be cytoplasmic maturation defect, like in case of if there is a deficient heme synthesis, so that would lead to iron deficiency anemia, or it could be deficient globin synthesis that results in thalassemia. Now there could be nuclear maturation defect, like vitamin B12 or folic acid deficiency, that can cause megaloblastic anemia. Or there could be hemopoietic stem cell proliferation and differentiation abnormalities, like in case of aplastic anemia. So where it is a condition where bone marrow, it will fail to produce sufficient red blood cells. Apart from that, bone marrow failure can occur due to the systemic diseases. Chronic diseases can suppress the bone marrow function. Anemia in the renal diseases, like in case of kidney, fail to produce adequate erythropoietin hormone, that leads to decrease in the red cell production. Other anemia could be due to the endocrine and nutritional deficiency. Anemia in the liver disease, liver dysfunction can also affect the RBC cell production. Leukemia, lymphoma, these are the cells that can invade the bone marrow. Multiple sclerosis, congenital anemia could be sideroblastic anemia, a genetic defect in which iron is incorporated into the hemoglobin. Anemia due to increased due to increased red RBC destruction. That could be hemolytic anemia. Now that could be either intracorpuscular, that means they are hereditary, and they affect the red cell membrane, enzymes or hemoglobin, or they could be extracorpuscular through the acquired conditions like red cell destruction. The second classification is about morphological classification. Like is the first is a microcytic hypochromic anemia. That condition, that here you will see reduced MCV, MCH and reduced MCHC. So example is iron deficiency anemia, sideroblastic anemia, thalassemia. So remember, microcytic hypochromic anemia, it is seen in SIT, that is sideroblastic, iron deficiency anemia and thalassemia. Other characteristic is normocytic, normochromic anemia. Here you will see normal MCV, MCH and MCHC. That would be seen in acute blood loss, hemolytic anemia, bone marrow failure, or anemia of chronic disorder. So remember that. Other is raised MCV. So that could be, example could be megaloblastic anemia due to deficiency of vitamin B12 or folic acid. The anemia of blood loss, it is categorized based on rate on which blood is lost. So when blood loss occurs suddenly, the following physiological responses and laboratory findings you would see. First of all, there would be reduction in the blood volume that can result in shock like situation. That would be the physiological response. So if the patient, he survives the initial threat, then the interstitial fluid, remember the interstitial fluid would shift into the intravascular compartments in order to compensate for the blood loss. So that result in heme dilution, and that result in decreased hematocrit. Apart from that, you will see the hypoxia. That means there would be reduced oxygen level in the tissues. That would stimulate the production of erythropoietin. that is a hormone. That produces increased that promotes increased red blood cell production in the bone marrows. So here the red blood cells, they are normal in size and hemoglobin content, but their number is reduced. So you would see is normocytic normochromic anemia. Apart from that, there would be lower hematocrit value, increase in the reticulocytes count. So that indicate that there is accelerated increase erythropoiesis in the bone marrow. In case of the chronic blood loss, the blood loss occurs gradually, allowing the body to compensate for some extent until the iron stores they are depleted. So when the loss exceed the rate of production and iron reserves are exhausted, the iron deficiency anemia would occur. Now, in case of what would be in the chronic blood loss, you would see is hypochromic microcytic anemia. That means that the RBC cells, they would be smaller in size and have a reduced hemoglobin content. The hypochromic anemia is primarily caused by iron deficiency anemia, but it can occur due to the other conditions. Now let us discuss the causes of hypochromic anemia. The first is the iron deficiency anemia. Now iron deficiency anemia, we note that the most common cause of anemia worldwide is the iron deficiency anemia. So iron deficiency anemia would impair the iron deficiency anemia would impair the hemoglobin. The iron deficiency anemia would impair the hemoglobin synthesis that lead to microcytic hypochromic anemia. The most common nutritional deficiency worldwide it's the iron deficiency anemia. Now what are the sources and losses of iron? The iron from food such as leafy vegetables, beans, meats, liver, they are the good sources. Daily iron losses can occur in adult male and non-menstruating female. About daily losses of 1 milligram of iron is lost, but menstruating women, they lost additional 0.5 to 1 milligram of the iron daily. Now iron, remember, it is absorbed mainly in the duodenum and proximal jejunum. Remember the heme iron, it is that is from the animal sources, it is better absorbed than the non-heme iron that have a plant source. Now what are the factors that enhances the non-heme iron absorption? Vitamin C, citric acid, amino acid, sugars, HCl, and gastric secretions. What are the inhibitor of non-heme iron absorption? Is the antacids, milk, pancreatic secretions, phytates, EDTA, and the tannic acid. So that is important for your entrance exam point of view. Now the iron, we know it's found in plasma, it is bound to transferrin. That is a beta globin synthesized in the liver. The transferrin, it transport the iron to developing erythrocyte cells. So there are many transferrin receptors that are present on many tissues. So this transferrin, it is recycled after iron is relieved. What is the storage form of iron? Remember, it's the ferritin and hemosiderin. So remember that the ferritin and hemosiderin, they are in the mononuclear phagocyte cells of liver. They store. Now the body cannot regulate iron content by excretion alone. So daily iron loss is about 0.5 to 1 milligram in both individuals. Iron, it's lost through the desquamation of epithelial cells, in the urine, you will see, in the sweat glands, in the hairs, in the nails, and mainly through the feces. Now distribution of iron. Iron is present. Distribution of iron in the body is through the hemoglobin that is present in the red cells, myoglobin, heme and non-heme enzymes. The storage form, they are ferritin, hemosiderin. So remember, iron deficiency anemia occur when the supply of iron is insufficient for hemoglobin synthesis. Initially, the body compensates by mobilizing the iron from the tissue stores. So once the stores, they get depleted, that lead to iron deficiency anemia. Now what are the factors that contributes to iron deficiency anemia? There could be increased bleeding, that could be from GIT tract, heavy menstruational periods, increased requirement like growth spurt periods, pregnancy, period of rapid growth in the children, or inadequate diet, poor diet lacking in the iron rich foods, or there could be decreased intestine absorption, like diseases like Crohn's disease, celiac disease. That could be the reason. So remember that men, they absorb around 1 milligram per day iron, and women, they absorb around 1.5 milligram. The daily iron, it is absorbed in which state? It's the ferrous state. So this ferrous state, it is converted into ferric state in the body. So the iron binds to the transferrin in the plasma for the transport. The iron, it is transported to bone marrow, where it is used for hemoglobin synthesis. So remember, daily requirement for the RBC synthesis, daily requirement is 2400 milligram in males and 1700 milligram in the females. The reticuloendothelial cells, they store around 1000 milligram of iron in the male and 300 milligram in the female. The iron, remember, it is used in the tissue for myoglobin and various enzymes, and it is stored in the liver as a ferritin or a complex that is known as ferritin apoferritin complex. Now the excretion of iron loss occur through the skin, GIT tract, etc. Male lose around 1 milligram and female, they lose around 1.6 milligram. The mature red cells, they have a lifespan of 120 days and they are phagocytized by reticuloendothelial cells. The iron from these cells, it is recycled and stored as ferritin hemosiderin complex. Coming to the etiology of iron deficiency anemia, the iron deficiency anemia, it arises from various factors either that increase iron loss, that could be uterine bleeding, like in case of heavy menstruational bleeding during the reproductive years that deplete the iron stores. Young girls may experience heavy bleeding during the onset of puberty, at the onset of menstruational. GIT tract causes could be peptic ulcers. There could be peptic ulcers can bleed and cause chronic blood loss, hemorrhoids in the rectum. They can lead to bleeding. Apart from that, there could be worms like hookworm, parasites that feed on blood from the intestinal lining. There could be esophageal varices. The swollen veins in the esophagus, they can rupture and bleed. Other could be hiatus hernia. It is the part of stomach that can cause, that pushes into the chest, that can cause bleeding. Apart from that, long-term use of aspirin even can cause GIT bleeding. There could be renal tract cause, like blood in the urine due to various urinary tract infection. The presence of hemoglobin in the urine. There could be nose bleeding. The pulmonary causes could be coughing up of blood from the respiratory tract. There could be growth spurts that require more iron for increased blood volume and muscle mass. Other causes could be pregnancy and lactation. The breastfeeding mothers, they require extra iron to produce milk. Inadequate dietary intake, like due to the poor economic status. Anorexia, reduced appetite can lead to insufficient dietary iron intake. Difficulty in chewing. Like in case of gastrectomy, when the part or all of the stomach has been removed, that reduces the area that is available for the iron absorption. Presence of HCl in the stomach, that would also impair the conversion of iron to its absorbable state. Intestinal diseases, malabsorption diseases like celiac disease, that could be the cause. Now, what would you see? The clinical features would be weakness, fatigue, dyspnea, palpitation, pallor of skin. That could you could see is long-standing IDA. It can cause, like the main important is cholynychia. That is, the nails here, they would appear as a spoon-shaped nails. The tongue would be inflamed, and term we use is atrophic glossitis. And there would be shores, mouth shores. The term we use is angular cheilitis. And apart from that, you would see esophageal changes that leads to dysphagia. So these all are feature of Plummer-Vinson syndrome. Now the laboratory findings. First of all, the hemoglobin is the anemia can vary from mild to moderate. So hemoglobin occasionally might be less than 6 gram per deciliter, that could lead to severe blood loss. The red cells in the blood film, they are hypochromic and microcytic, and there is anisocytosis and poikilocytosis. So hypochromia is due to the poor filling of the red blood cells with hemoglobin, so there is increase in the central pallor. So in severe cases, there may be only a thin rim of pink staining at the periphery. Apart from that, you can see is target cells and polychromatic cells. The reticulocytes, they are remember the reticulocytes, they are either normal or they may be reduced. So the MCV, MCH and MCHC, all they are reduced. The platelet count is usually normal. The total and differential WBC count, they are again normal. Apart from that, you can do is bone marrow finding. The marrow cellularity, it is increased due to there would be the myeloid erythroid ratio that decreases. So here you would see is predominance of small polychromatic normoblasts that are known as micronormoblast cells. So these have a thin rim of cytoplasm around the cell and they have a ragged irregular borders. Other cells, myeloid, lymphoid, megakaryocytes, they are normal. So if you do iron staining with the Prussian blue on bone marrow aspirate smear, they show deficient reticuloendothelial cell stores. Apart from that, the biochemical findings that you would see is the serum iron level is low. Normal value is 40 to 140 microgram per deciliter. The total iron binding capacity is high. Remember, in case of chronic anemia, this total iron binding capacity is decreased. The serum ferritin level is low. That indicates that there is indicating poor tissue iron stores. The serum ferritin is raised in iron overload and it is normal in anemia of chronic diseases. Now the treatment of iron deficiency anemia is correcting the disorder that is causing the anemia. You have to identify the cause. You can correct the iron deficiency through iron replacement therapy that can be given orally, or iron IV can be given. Oral iron can be given like ferrous sulfate, ferrous gluconate tablets can be given. Remember, iron should be ideally taken on empty stomach. Apart from that, parenteral iron therapy that can be given when the oral irons, they are poorly tolerated, like in case of GIT side effects, malabsorption syndrome, or when there is severe anemia in the pregnant women. IV or IM injections of iron can be given that include the iron dextran, sodium ferrous sulfate, iron sucrose that can be given.